It's important to assess quality of life for patients with bone marrow failure conditions, just to make sure that we are integrating how people feel as a part of their care. A lot of times, science is not necessarily focused historically on the patient experience. It is more focused on labs or now more genetic information. But what we've learned over time is that how patients feel actually has a very, very big impact on their disease, on the status of how they're doing, how they're going to improve over time. So being able to pull all of that information and also just make a tough experience a little bit easier is really important. Quality of life in MDS, numerous tools have been developed to try and integrate how you feel into something more quantitative that we can use in terms of management. In all of our new therapies, one of the tools is that they build in how you feel into how your treatment is going. So that can make adjustments in terms of your treatment itself, meaning either changing the medication, the dose, the plan, based on how things are progressing, or simply moving to a different therapy because it's working or not working well enough. Psychological well-being is the elephant in the room because we're oftentimes focused on disease, but we have to think of everything, the people as people. And many of the tools we talk about implementing is one, obviously checking in with patients directly about how they feel so that they feel supported and are able to express themselves when issues come up freely, knowing that it's not going to affect their care in any negative manner. And then sometimes for patients, if they don't feel comfortable talking to their physician, there are many support services like social work or palliative care, which sometimes has a bad name, which we go by symptom management or symptom control teams. So when we pull all of these things together, it makes a hard disease process a little bit easier. Transfusion burden is one of the biggest barriers for patients with AML and MDS to live relatively normal lives. Over time, we've moved towards therapies which are a little bit easier, sometimes oral, things that you can do, on your own time, not restricting you to the hospital as much as they did about 10 years ago. But the problem is sometimes when we give the therapy or the disease itself drops your blood counts to a point that you are somehow chained to a medical facility, which restricts things like travel, or makes people drive 3 hours a day to, have their labs checked. Sometimes the blood is not available, so they have to do that 2 days in a row. Apart from the patient, it actually really affects your caregiver as well because they can't work as much, or they have maybe children that they need to take care of. So it's a big burden, and being able to create either therapies that reduce transfusion burden or eliminate it altogether is one of the key goals. For patients who have lower risk MDS, meaning like we want, they will live a long time, we also want them to feel better. And a big factor with having low blood counts is either being very fatigued or bleeding. So being able to control those factors without having someone come into the doctor's office all the time is a very, very key goal in our patient management. Palliative care teams are so helpful in making people feel better. And one of the big stigmas in society and with doctors is that palliative care means end of life. And I think one of our goals needs to be to move away from that stigma and consider it as a second set of eyes for people who are looking out for your well-being. Maybe someone needs to talk about their feelings outside of their doctor's appointment. Maybe they want to talk about, the nausea is pretty bad and the medication is making it worse, and they don't want to address that with their doctor. So it's a second set of eyes, it's a second brain that's helping come up with ideas of how to make your life better. And I think that's how we need to conceptualize this moving forward. Also, at times there are difficult decisions to make. So what I mean by that is, many of these illnesses at variable time points may lead to death. So making that process of transitioning when you are already under distress, having palliative care on your side is very, very helpful. And there's so much medical data to support this. It's just we have to improve our integration long term with these services working side by side. Your oncologist and your palliative care doctor being having one goal, which is making you feel better. I think for patients, it's important to always be as transparent with your doctor as possible. Something we've heard repeatedly is that they don't necessarily want to tell their doctor about certain symptoms because they're worried that will change our chemo plan or, limit their next steps. But I would argue or even, sort of reassure you that those will make your decision making much stronger so that you can live your better life for longer. I think one other factor is, and I already said this, but don't see palliative care as the end. It is simply something that makes your life better.